Welcome to This Explainer. You know that incredible sense of relief when your ears finally pop after a long flight? Well, you have a tiny yet absolutely fascinating piece of biological engineering to thank for that. Today, we're diving into the anatomy of the ear's internal pressure valve, the pharyngotympanic tube.
Here's our roadmap for today. We'll quickly cover the tube itself, its bony and cartilaginous parts, the vascular and nerve supply, how it actually functions, its clinical anatomy, and wrap up with a special acknowledgement.
All right, part 1, the pharyngotympanic tube, or as it's subtitled here, an introduction to the ear's trumpet.
You probably know this structure by its more common name, the eustachian tube. But honestly, its medical name, the pharyngotympanic tube, tells you exactly what it does. It's this trumpet-shaped channel that literally bridges the gap between your nasopharynx, so the back of your nose, and the tympanic cavity, which is your middle ear.
Now, despite doing some major heavy lifting for our hearing and overall comfort, this entire channel is incredibly small. We're talking just about 4 centimeters long. From the middle ear, it angles downwards, forwards, and medially, diving straight into the base of the skull.
And it doesn't just wander aimlessly down there. The geometric precision of our anatomy is wild. This tube sits at very specific structural angles, exactly 45 degrees with the sagittal plane and 30 degrees with the horizontal plane. It is positioned absolutely perfectly to do its job.
Moving on to section 2. Let's break down its structural blueprint with the bony and cartilaginous parts.
So, the tube is basically split into 2 distinct sections. The posterior and lateral 1/3 is entirely bony, and that makes up just 12 millimeters at the length. The rest of it, the anterior and medial 2/3, is the cartilaginous part, coming in at 25 millimeters. Put them together, and you get that crucial 4-centimeter bridge. Looking at this diagram, you can really see how these 2 parts connect. The wide lateral end of the bony part opens right up into the middle ear. Then it kind of pinches down at a spot called the isthmus before merging with the cartilaginous part. That cartilage forms a triangular plate, ultimately creating this noticeable little bump called the tubal elevation right where it opens into the nasopharynx. Now, this tube definitely does not exist in isolation. It sits in a very busy, highly connected neighborhood inside the petrous temporal bone. The bony portion is bordered above by the canal for the tensor tympani muscle. Medially, it's right up against the carotid canal, and laterally, it shares the wall with your jaw joint, the temporomandibular joint, along with some important nerves like the chorda tympani. As we move medially over to the cartilaginous section, the neighbors change. This part is essentially a triangular plate of cartilage curled into a tube, with the rest of the wall closed up by a fibrous membrane. It's super close to some critical muscles. Anterolaterally, it's chilling next to the tensor veli palatini and the mandibular nerve. Posteromedially, it neighbors the levator veli palatini. Keep those muscle names in your back pocket because they're going to be a huge deal when we talk about how this thing actually works.
All right, section 3, vascular and nerve supply. Let's look at the wiring and plumbing.
The blood supply here is highly specialized. It's fed primarily by the ascending pharyngeal and middle meningeal arteries, plus the artery of the pterygoid canal. Once the blood drops off its oxygen, the veins drain out into the surrounding pharyngeal and pterygoid plexuses. And for immune defense, the lymphatics route directly to the retropharyngeal nodes. The nerve supply is just as dynamic. Actually, the innervation literally shifts as you travel down the tube. At the opening, or ostium, it gets its supply from a pharyngeal branch of the pterygopalatine ganglion. The middle cartilaginous part relies on the nervus spinosus branch of the mandibular nerve. And finally, the bony part is wired by the tympanic plexus, which comes from the glossopharyngeal nerve. It is a total patchwork of sensory input.
Which brings us to section 4, function of the tube, the pressure valve.
Here is the absolute key takeaway. This tube acts as a highly sophisticated pressure release valve for your eardrum. By connecting that sealed middle ear cavity to the outside world through the back of your throat, it ensures the air pressure stays equal on both sides. If that pressure gets out of whack, your eardrum can't vibrate properly. The result? Muffled hearing, or worse, a whole lot of pain.
But here's the thing. It doesn't just sit open all the time. Usually, the tube is closed off. It needs mechanical action to open. Remember those muscles I mentioned earlier? The tensor and levator veli palatini? Whenever you swallow, yawn, or sneeze, those muscles contract. That pulling action literally yanks the cartilaginous tube open for a split second, letting a tiny bubble of air pass through to equalize the pressure before it snaps right back shut.
Section 5, clinical anatomy. Let's talk real-world application. If you've ever had a nasty common cold that turned into a miserable earache, you've experienced eustachian catarrh, which is just a fancy term for inflammation of this tube. Because it opens directly into the back of your throat, infections can easily travel up, swell the lining, and block the tube entirely. That causes pain that gets way worse when you swallow. Why? Because your muscles are desperately trying to yank open a tube that is swollen shut. Popping some decongestant drops in your nose helps shrink that swelling and open the ostium back up, which brings some much-needed relief.
This next bit brilliantly explains a universal parenting struggle: childhood ear infections. The text here clearly states that infections passing from the throat to the middle ear are way more common in kids, specifically because their tube is shorter, wider, and straighter.
Just look at the anatomical difference here. In an adult, the tube angles downwards, right? That gives us a natural gravity barrier against throat bacteria creeping up into the ear. But in a child, it's basically a short, straight, horizontal water slide. Pathogens from a runny nose just take a direct, unimpeded highway straight into the middle ear cavity. To make matters worse, kids have another structural risk factor. That opening in the throat, the ostium, is frequently blocked in children because their tubal tonsil gets enlarged. So you combine an enlarged, inflamed tonsil with a short, wide, completely straight tube, and it's suddenly very obvious why childhood earaches happen all the time.
Finally, Section 6, Special Acknowledgements. Let's give some well-deserved credit.
A massive thank you goes out to Dr. Vikrant Tripathi, Associate Professor of Human Anatomy at the University College of Homeopathy in Jodhpur. Dr. Tripathi contributed the foundational textbook material and those incredibly helpful anatomical diagrams that made today's explainer possible. We seriously appreciate his dedication to medical education. So, I'll leave you with this. The next time you're on a flight taking off and you swallow hard to make your ears pop, take a quick second to appreciate the complex structural machinery working right inside your skull. Will you picture your tensor veli palatini muscle dynamically yanking open your 25mm cartilaginous pharyngotympanic tube? I know I will. Thanks for joining me on this explainer, and stay curious.